So I think this bears further discussion. There's a lot of cynicism because when the markup on drugs, which everybody recognized, both the provider and the payer side, was the dollars that supported everything you just said, all the things you just said, got cut significantly, now to 4.6% above what it costs to buy. There was not, as was promised, a commensurate increase in the E&M code reimbursement. And that's what has put oncology practices across America under significant stress.
But let's remember, that's for Medicare, okay? So every oncology, and we used to preach this in U.S. oncology, every practice in America knows that Medicare, treating a Medicare patient in the office is break-even business, maybe. But, and so the profitability of a practice, and actually the survival of practice, depends on their relationship with their commercial payers.
But many of the private payers now, Mike, as president of RCCA, I'm responsible for over 110 oncologists, 25,000 new cancer patient diagnoses a year. Many of the private payers are following in the Medicare model. So, but here's the point I want to make. What you're describing, and maybe this will be a good transition to the new methods of care, is how do we move from being paid for services to being paid for a product? In other words, if someone comes in with stage 2 breast cancer that's HER2 positive, we all sort of agree how we should approach that patient. We all sort of agree how many tests we should get, how many images we should get, maybe plus or minus a little bit, but it's not that far. How do we move from getting one check, like in bone marrow transplant, I'm a bone marrow transplant doctor, I get one check. And that one check covers everything we do, and all the doctors, and the hospital, and everything. Is there a possibility to move towards that sort of thing where there is proper reimbursement commensurate with what should be done and not what people do?
One of the big challenges, I think, is that in the bone marrow transplant example, those case rates are really paid to a physician who has a relationship with an institution, a hospital, and there's a clear start and a clear stop. And there's stop loss, of course, which is invoked in many, many, many transplants. So the issue with caring for solid tumors is biological variability increases the complexity of how many such episodes or bundles exist. Second of all, oncologists, if they're not in the employed physician model, utilize resources, often from multiple other providers, over which they have no leverage to negotiate a contract or price. And so let's just think about your putative example of an adjuvant patient. Most of that patient's costs are going to be related to chemotherapy and office-related charges. There'll be some imaging. Hopefully, if things go well, not much hospitalization, because we know that although it's annualized 2 ER visits, 1 hospitalization per patient, that's not per episode, that's per year.
Right.
And let's be clear on that. That's very, very important because not every patient who gets treated for early breast cancer gets hospitalized. In fact, very few do.
Right.
So I think that complexity of the multiple clinical decisions that impact the total cost of care, but the fact that the physician, although he might be engaged in decisions that impact those costs, doesn't personally enrich himself. So you have to somehow indirectly reward the physician for, if you will, good behavior. And it gets to be really, I think it gets to be really complicated, right? Does the oncologist hold the episode? When does the episode start? How long does the episode go? Do I think that's ultimately where we're going to go? Yes, I do. I think that's where we're going to go.
Jeff, you've thought a lot about this.
Yeah, I have real problems with bundles. And my problem with bundles are not that I don't think that they might be able to work, but I think that you have to be very careful about how they're constructed and what you're doing. You know, my personal migration has been from a small private practice to a larger U.S. oncology practice to a foundation practice supported by a hospital to integration into a hospital system. So I had this personal consolidation that I've watched happen in my practice, and I think that bundles will prove to be, if we do them wrong, a way that will further that consolidation and further the movement into institutions, whether that's good or bad. And I think the reason it will do that is that you have to decide, am I going to make bundles that are very granular or very broad? If they're very granular and we begin defining disease molecularly, I now have hundreds of bundles that an insurance company has to manage and that have to be calculated, have to be done. If you're talking about Medicare, they can't calculate ASP anymore often every 6 months. How are they going to manage 100 bundles and keep them updated and put new drugs in and take care of them? I think that's a huge undertaking. On the other hand, if you have very broad bundles, so you now have an adjuvant breast cancer bundle, and you're in a small practice, and you've got some patients that are needing no chemotherapy and they're just being treated with hormonal therapy, and then you have your HER2 positive cancer that gets Herceptin and pertuzumab in a neoadjuvant setting, and then you're responsible for their surgery costs, and now for further chemo, for another full year of therapy, and you get a few extra HER2 patients in your practice that year, you're dead in the water. So how do you manage that kind of risk in a bundle? You get big.
So let me address that, because we were actually doing that. So what we found was, you can take the complexity of breast cancer as an example, and there's, I'll make up a number, maybe 3,000 different phenotypes of defined breast cancer today. Now with next generation sequencing, maybe that goes to 5,000. But we've been able to fit those 3,000 into 6 different bundles that accounts for what you said, and we're actually doing this in practice. Now we've been only doing it a year. So far so good, we'll see. So I do think it is possible. But let me ask you both, because you both made the point that oncologists today are under significant duress, that I think we all agree site of service does impact cost, that the best place for a cancer patient to get their care, we believe, is in the community setting, in a private office, when it's non-quote-unquote quaternary care, like a bone marrow transplant or a phase 1 trial. And even there, the phase 1 trials maybe a little bit. But if we're going to preserve that model, if that truly is a better economic model, what do you propose we should do? I'll start with you, Mike.
Yeah, so I think the truth is that a lot of community oncology practices have focused a lot of their business efforts, operational efforts, on the efficient administration of chemotherapy. That's what they do. They do it well. What I'm proposing is that we need to rethink and potentially retool to deliver the optimal patient care experience. Mm-hmm. And so it would be wonderful, and this is perhaps aspirational, I'll grant you that,
okay,
as we make it simpler, right, by whatever methodology that we pay for chemotherapy. Mm-hmm. If we make it simpler to navigate that business challenge, then we can retool the office to start thinking about how to answer the phone better. I mean, that sounds
right,
trivial, but there's a really interesting article I read, a study that showed that the success of a primary care medical home was actually directly related to how effectively they handled triage.
Sure.
Now, we've been in practice, we know how true that is, right? Whatever the nurse is that's doing the calls that day, you know what's gonna happen, right? Whoever the incident 2 physician is that day, you know what's gonna happen, right? So all I'm saying is, we need to get practices comfortable with the idea of examining processes of care. And I'm not sure that's going to cost a ton of money, but it does require a lot of effort on retooling. Listen, I spent years trying to change triage in my office, and I failed miserably because we had 38 doctors and 8 sites of service, and we just couldn't agree on the same color chart for patients when we were on this, together. So getting everybody to answer the phone the same way, and my hat's off to Barb McEnany for what she's done. I mean, she's done a great job in terms of proving that you can do it. You can do it with multiple practices, but you got to have force of will. You got to have Barb barking at you.
Right.
And it can get done. But the truth of the matter is, I think that's what needs to happen. We need to start thinking about it. And then we need, of course, to reward people who do that very, very well.
So there's all these acronyms, Jeff, OCM, medical home. I mean, it's all basically how do we avoid unnecessary emergency room visits, hospitalizations, reduced length of stay, and overutilization of diagnostic testing and imaging. So how do you propose to address that?
Yeah, so I struggle with the OCM model because I don't think that it's really dealt with some of the core issues. A lot of the models out there, OCM wants to want to call that a bundle.
Right.
It's not a bundle.
Right.
It is fee for service and shared savings.
Right.
And they're just basing the shared savings on a calculated bundle. That's the only place a bundle comes into it. And when you have fee for service over here and you have shared savings over here with this bundle thing, you've got two incentives. You have an incentive to do more, and you have an incentive to do less, and you're hoping that somehow two wrongs make a right and you end up in the right place in the middle. And you have some quality measures to try and do that, and they're not going to be in-depth enough quality measures to really demonstrate that you're providing great care and that you've landed in the right spot.